It is a huge honor today to be podcast interviewing Mike Ragan. We're in Phoenix, Arizona at the Henry Schein Orthodontics Symposium. And Mike, you're a practicing orthodontist for how many years? 20 years?
Almost 20 years.
20 years in Dallas, Texas.
In Dallas, Texas.
Thank you so much for coming on our show today.
Yeah, thanks for having me.
So this is like the most prestigious lineup of orthodontists in the world. I mean, Henry Schein, they truly wanted the 10 biggest names in dentistry. So congratulations on being that caliber.
Well, thank you.
To be on that program. No, it's
blessed.
Yeah, well, it's quite an honor to be on this program at the Biltmore. What are you talking about tomorrow? You lecture tomorrow.
I do, and tomorrow I'm talking about the SLX bracket, which is a...
Say it slower. SLX?
SLX.
SLX.
Yep, bracket.
Bracket.
It's Carrier, Dr. Carrier's bracket.
And Dr. Carrier is Louis Carrier, Carrier.
Yep.
From Barcelona,
Spain.
Barcelona, Spain. And you're talking about his bracket.
And his Class 2, Class 3 corrector called the Motion Appliance.
Class 2, Class 3.
Yep.
Motion.
Appliance. Yep.
Okay. A lot of dentists say that there's nothing you can do with the Class 3 unless it was surgery.
I would debate that severely now, and I would have said the same thing when I started this process with them. So I started when Dr. Carey was selling his wares through a little company out of Lubbock, Texas called Class 1 Orthodontics, which has now been folded into the Henry Schein brand. And when I started with it, the only thing I knew it could do was Class 2 correction, and I doubted that even. And as they asked me to try it, being in Dallas, not far from them, I tried it. It was amazing. So I took that and ran with it and tried it on the Class 3. And sure enough, it worked, especially in young kids. So I started incorporating it like that and then found out that Dr. Carrier was doing the same thing. And I can promise you it will correct a Class 3 many times without surgery. Now, I still talk about surgery with my patients because certain types of grower, the amount of space that's available, you can't correct everything with the Class 3 motion. But you can correct many of these Class 3s without going to surgery.
So a lot of people say no matter what you do when the child's being developed, the mandible is just going to grow its own shape, period. And that with retainers, you're not going to make it grow longer, you're not going to hold it back. It's going to grow to its designed genetic shape. True or false?
I would say true, but you can have an effect on that direction and the velocity of that growth. So if you're changing the direction into a more normal growth pattern, and the inherent growth is not going to make a negative change, it's actually going to help you in many cases. So I'm not trying to make the mandible longer or shorter. I'm trying to put it into a more positive direction in that growth to make it blend with, in this case, the maxilla. We're talking about the mandible, so blend the maxilla and its growth direction and modification with the mandible. That's what we're trying to do.
And that Class 3 is in a totally different position depending on the tilt of the maxilla.
That's right. So some people will look like a bulldog with their low angle. Some people are going to have more of an open bite, very long face, and a higher angle. So you have to do different things in each case to try and correct that malocclusion. Yeah,
my mom said I had a face for radio. That's why
I think I have the same thing.
That's why I try to do all mine on iTunes and not YouTube. So what's got you? So is that what you're talking about mostly? Is that what you're mostly passionate about?
I am. My real passion is two things: is sports dentistry, especially mouth guards. I do a ton of mouth guards. I've been the NCAA dentist for the Final Four in the grade 8 in Dallas, and learned all my stuff from Ray Padilla out of California. And love sports dentistry. I played college baseball and did a bunch of athletic training classes when I was there, and it's still something that I love to do. And my other passion is young kids, phase 1 treatment. Your 6 to 10-year-olds and trying to make a positive change in their life.
So phase 1 is 6 to 10?
Well, it depends on it's mixed dentition.
It's mixed dentition.
But it's trying to find in each of these kids the right timing to do that treatment.
So let's go back up to sports dentition.
Yeah.
It seems like in the full contact sports like football, I've never seen a tooth injury. Because they're ready for it.
Right.
They got headgears, mouth guards.
Right.
It's the, quote, non-contact sports, like basketball.
Yes.
Well, if it's non-contact, then why are there fouls?
Right.
And
right.
I've had more people go up for a layup and get an elbow, a knockout, and inside. Isn't it bizarre how the non-contact sports have all the tooth avulsions? I mean, so
It's true.
Talk about sports dentistry.
Yeah, so what people don't realize is that most dental and facially injured sport in the world is soccer, and number 2 is
No.
basketball. Yes. You can think about the
Soccer.
same thing. Everybody views soccer as a non-contact sport, but anybody who's watched it knows it's not just contact with other players, it's contact with the ground. And a header, it's contact with other heads. It's contact with the goalpost in certain circumstances. So from an injury to the face, not necessarily just to the teeth, but to the face and head, it's the number 1. Basketball being number 2. If you look up Dirk Nowitzki from the Mavericks, which is where I'm from, there's a video of him getting his own tooth knocked out, and there's a video of him knocking somebody's tooth out. So you're right, basketball is one of those big ones.
You know why soccer will always be the number 1 sport in the world?
Why is that?
Because it's the lowest cost.
I could see that.
I mean, all you need is a ball on the ground. When I'm in
That's true.
Brazil, those little kids, in a rich country like ice hockey, how is ice hockey going to take off in Asia and Latin America and Africa?
Right.
They're not going to build rinks for it. There's 1 billion people in Africa. You can't build them all ice rinks. But soccer, you just need a ball. When I was in Brazil, you know how over here in rich America, people have these shirts like, with their favorite sports guy on it and the number. Yeah. In Brazil, they take charcoal and write the number on their bare back and the name, and they just have a ball and they're barefoot. It's so low cost. It'll always be number 1.
I get that.
And ice hockey in the Winter Olympics will always be dead last because it's too much money.
I think one of the interesting sports trends, though, is lacrosse, which is the growingest sport in the world right now. And I've gotten into that because my kids go to a school that has it.
Can you play that on a soccer field?
You play it basically on a soccer field, soccer or football field. It's actually, the fields are usually the length of a soccer field and the width of a soccer field, much bigger and wider than most regular sports fields.
And it's probably low cost. You just need one thing, right?
Well, no, it's actually pretty high cost. Those sticks are quite expensive. It's a very specific type of goal in size and shape. And you do require a lot of protection in the guys' game. In the girls' game, it's goggles and mouth guard only. So it is a higher cost sport, but this is getting pushed into some of the developing countries. In the World Cup that just happened 2 years ago, there were African countries that were competing, and so it's picking up steam. It's something that was invented by the Native Americans, and they did it over miles and miles of terrain, not just a small sports field.
Who invented? Native Americans invented what?
The lacrosse.
Native Americans invented lacrosse?
Yes.
Native American Indians.
They did, and they used a I can't remember what the wood that they used to make their stick, and a little netting off to the side, and they would play this game over many days, over many miles.
Well, I'm gonna start a new business. What I'm gonna do is I'm gonna take one lacrosse stick, I'm gonna send it to IKEA, and get a bid on them making me.
I'm sure they've got it somewhere.
I'm sure they could get the cost down to $1 a stick. So in sports dentistry, do you have is it mostly making mouth guards?
That's the big component of it, but it's also making mouth guards for each type of patient. So if an athlete has had an injury to one of the anterior teeth, you'll add an extra layer in fabrication of the mouth guard. So it's not the ones you just get stock off of the shelving. Those are stock for everybody. The ones we make custom are actually designed to help protect each type of sport. So lacrosse, basketball, where the majority of the contact is going to be right in the anterior, we add a little extra layer in the front part of the mouth. And it's called multi-lamination. So you add layer upon layer to get the right thickness so that you can protect those teeth. Now, if someone has had a concussion in the past, you'll add layers to the posterior teeth, opening up the bite, moving the condyle away from the fossa, so that the acceleration to the lower jaw can't cause a lower area of concussion near the TMJ. So it's designing different mouth guards for different situations.
Do you have a lecture on that?
I do a little bit of that.
Because my God, I mean, I've never. This is all news to me. On Dentaltown, we have we put up on the online CE, we put up 350 one-hour courses. They've been viewed 750,000 times, and we don't have a mouth guard lecture.
I think I've seen Ray Padilla quoted, I thought, in one of the dental towns many years ago, a couple of years ago.
Yeah.
So Ray Padilla is the one who taught me. I got to give him all the props. He's out of San Diego, California.
So how do you spell Ray Padilla?
Padilla is Padilla.
Hey, hang on, R-A-Y, Ray, and then how do you spell Padilla?
Padilla.
I-L-I-L-A. It says dentist. Oh, Manhattan Beach. Okay, so not. So is he?
That's him right there.
Right there.
And he bases his love and desire for this from his own past. He had an injury as a kid, and he calls himself a dental cripple. And the reason is this anterior part of his mouth, he's having to constantly redo it. We know nothing in the mouth lasts over the lifetime of a patient. I was compared to a boat on the water. You buy a boat to be on the water, but as soon as you're done with it, you take it out of the water. And that's because of corrosion. Same thing in the mouth, it's going to break down. So Ray has gotten into it because of that. And my sports background, I went to one of his courses and fell in love with it.
And so that's his actually sports dentistry.
He's been part of the U.S. Olympic group that outfits the Olympians, and has gone to, I can't remember, it might have been London. He was on the dental committee that was there making mouth guards for anybody who wanted it. So,
wow. So so now let's switch from anything else about sports dentistry. I mean, I went right to night guard. Is there any other big aspect of sports dentistry that they should be thinking of?
It's more advocating for prevention. So a couple of the states have mandated all sports, soccer, all the sports, to have it through the high school level. So Pennsylvania, for example, has it. That's a mandated rule. So that's part of what we're doing, is trying to advocate through the legislature and then training multiple people, dentists, pediatric dentists, orthodontists, to be that first line of defense to try and encourage kids to wear more mouth guards. So it's more on the prevention side, the rest of it.
Right on. So then, why does you said what gets you excited is sports dentistry, and then phase 1 mixed dentition.
Yes.
There are some blogs I have been reading just even recently that a lot of people think phase 1 is a waste of time and a waste of money. Have you heard some of these people say that?
Definitely. And
Definitely.
a lot of that is based off of some research that came out that talked about phase 1 treatment isn't needed. You can wait and do it all in one phase later in your life. Well, that's talking about treatment efficiency. Yes, I could wait and treat all these patients when they hit that maximum growth spurt. But what it neglects to take into consideration is a couple of factors. Trauma, and that's another reason I like this, is that the most traumatized time for dentition is somewhere between age 5 and 10. And the reason is kids are becoming more sports aware, they're more active, but they're the least coordinated. So this is the time they're more likely to injure their anterior teeth. If you look after, most of the studies are done by the pediatric dentists, and the numbers increase based off of certain types of bites. So class 2 bites, anything beyond 2 millimeters, the incidence of trauma increases. And in some of the studies, it shows that it doubles. The other component is what's called lip incompetency. So when they're at rest, if their lips have to be forced together, they're more likely to be traumatized as well. So the trauma factor isn't taken in consideration in these studies because they're looking at single factors. Efficiency of treatment. Can you wait and do it later? The other component is something that drew me into it. I was a class 2 kid, and I was bullied as a child. And psychosocial development happens somewhere between that age 8 and 9 and teenage years. And right now, with social media being so upfront, kids are bullying not just in person, but they're bullying each other on social media. So it's a way to help some of these kids to lessen the trauma factor. And people don't even think about this, but the most traumatized and sent to the hospital, anything that a kid uses is a trampoline. And the most avulsed teeth happen from the netting on a trampoline.
You hear this, Zach?
So that's if you watch netting on trampolines, they've changed. Netting used to be the open netting like you'd see out at a baseball field. The netting now is closed because the open netting was catching the teeth as you fell and avulsing the teeth.
You know,
so they changed the netting over time.
The most stress I ever had is I raised 4 boys, and now they're all raised. But we had a swimming pool and a trampoline.
Yeah.
I can't tell you how many nightmares I had that one drowned in the pool and one snapped their neck on the trampoline.
Yep.
And I just, you guys loved it so much. I mean, you just, the hours they spent in the swim. Well, I live in the
Well,
desert.
that's what you want them to do too.
But God,
Right. You want everybody to be outside and playing and having fun.
One of them turned into a quad, or one of them drowned.
Right.
And then
Right.
you just wish that you would have lived in a cave in the mountains.
I know, and I think that way. I have 2 daughters, and I think that way with ripsticks, scooters, hoverboards. These are trauma factors. How many parents came out of Christmas 2 years ago with broken limbs because they thought they could get on it and do what their kids could do? And it's a pretty high number. So that trauma factor, people don't take into consideration. They're doing. My kids were competing in a Iron Kids triathlon, which is usually sponsored by the YMCA. One of the kids hit a bump in the road, went over the handlebars, knocked out 2 of his front teeth, and chipped another one. I've never heard of anybody injuring their teeth on a bike. Arms, backs, I got stitches when I was on my bike. So I was thinking about those sorts of things when I do this phase 1 treatment. And really the psychosocial thing is huge because, one time, look at the suicide rate, and many times it's because of bullying, teasing by other people.
But is this trauma too? Is it more likely in males than females?
It is. But with the increase of females participating in sports, the numbers in sports are coming closer together. Now, overall, it's still boys because boys are just more active, usually outside of it. But if you take my youngest daughter in consideration, she's like any other boy. She's going to be out there doing her thing and with the boys many times. So, yes, the numbers are much higher in boys, but boys have malocclusions too.
So what more phases? This is Dentistry Uncensored, so I'd like to talk about controversial things. So I'm going to hit you with a hard-hitting question.
Oh, goodness.
So endodontists don't mind lecturing to general dentists. Oral surgeons don't. Pediatric dentists don't. They all lecture to general dentists. It seems like the orthodontic community is the most, we're over here. It's a separate club.
Right.
What way is that? Is that changing? Will it always be that way? Like if you went to your endodontist and said, "Will you help me with endo?" He'd say, "Yeah."
Yeah.
Like in Arizona, and I always tell these kids, I said, "You got $350,000 student loans. Why are you flying across the country to learn endo? You want to learn endo? Call your damn endodontist in the same building across the street." And then they always say, "Well, he doesn't want to show me endo because then I won't refer to him." And it's just that's completely wrong with endodontists. Oral surgeon, you want to learn how to place implants? Go stand next to your oral surgeon and periodontist. But orthodontists, they see that completely different. Do you agree with that or disagree?
No, I do,
So you do agree with that?
I do agree with that, and I think there's.
Where does that come from? What is that?
Well, I think so. My perspective is a little different. So I serve on the American Association of Orthodontists Council on Communication. So we're the ones that study where all the patients are coming and going and where our advertising campaigns should go to foster patients to come and see orthodontists. And I think it stems from the fact that one of the easiest things to incorporate into your practice right now on a general dental side is Invisalign. And I know there's been probably many things in the past that were the same way that's led down this path. But I think Invisalign has exacerbated that because practice management people, the general dentists themselves think it's so easy to do, and then they start doing it, and then many times they get in trouble. If you knew the number of times I bail out general dentists from doing things, especially Invisalign, it's a higher number than I ever thought it would be. And I think it's partly that. We're trying to make sure that the public is protected and doing the right thing, number one. And number two, it is, why would you not go to a specialist if you could go to a specialist? And I think there's many things that I tell my general dental friends, you got a little bit of rotational bone, go do it yourself. It doesn't matter to me. If you don't want to do it, I'll take it from you. But I think some people feel threatened overall that, especially with the growth of big corporate offices, that more and more of that general population are going to pull from their own private practices and lose that revenue. So I think it's multifactorial. But
Yeah.
I think that the numbers show that more general dentists do orthodontics than orthodontists do.
Say that again. The numbers show that what?
That more orthodontics is done by general dentists than by orthodontists in total. Now, one orthodontist does a ton more than a single general dentist, but if you add up the general dental population.
So there's only 10,600 orthodontists in America, and you're saying they do less ortho than the 161,000 general dentists.
I think if you looked at the numbers, it's going to be more of that. I can tell you in the state of Texas, we knew that from Medicaid. Medicaid in the state of Texas was frauded for $187 million in a single year. And there was more than that. But
in just dentistry or total?
In just orthodontics. Orthodontic Medicaid. So
frauded for $187 million?
Yeah, more than every other state in the union combined.
Damn.
Yeah, it was a lot. So that has changed. The state recognized it and brought in insurance companies, so MCOs to come in and manage the system.
What is an MCO?
It's a managed care organization.
Okay.
So basically, it's an insurance company that's going to manage the program. In the past, the state was doing it themselves. And now, so I work with a company that every case is reviewed by a dentist. So if it's a general dentist. If it's a pediatric dentist, oral surgeon, orthodontist, we all review the cases. So the cases are being looked at. So when we looked at the numbers, or the state looked at the numbers, there was a lot more. It's almost 3-to-1 general dentists doing the Medicaid ortho in the state of Texas compared to the orthodontists. Now, some of the orthodontists had the biggest numbers because they're doing more of each of them, but there was more ortho being done by the general dentist than the orthodontists.
So technically, though, you're in Texas. Didn't Texas just get rid of specialties, though? I mean, technically.
Well, it's still in the court system right now.
It is still in the court system.
And it's
just to refresh our viewers. Explain just to refresh the lawsuit in Texas. Some of the viewers might not be aware of it.
Yeah. So there were 5 organizations that included the anesthesiologists, implantologists, and a couple of other dental groups. I can't remember which ones they were. And they went to the state and said that, in basic terms, they were saying that they were specialists because they did individual procedures. They did a lot of them. They had the CE to do it, and therefore they should be able to call themselves specialists because that's what they did. And they're really, I think, challenging the ADA, not necessarily Texas itself. It's ADA's recognition of each of the specialties and who regulates that and who is the credentialing factor for that. That's where I think it really goes to the state. That's why I went to the state.
Are you with the ADA, the American Orthodontic Association?
Yeah, AAO.
AAO, but that's a part of the ADA, right?
No, it's a separate entity, completely separate entity.
It's completely separate?
Right.
It's not a branch of the ADA?
No, it's accredited. The specialty of orthodontics is accredited by the ADA. And so to be an accredited specialist, you have
You're the AAO.
AAO, American Association of Orthodontics.
I always thought those specialties were somehow related to the ADA, but they're not really?
No, and at one point you had to be an ADA member to be an AAO member. That's not the case anymore.
Okay, that's what it was.
Yeah. So it's a
what it was
completely
my
separate entity run with
Where's
separate
your
people.
headquarters?
Now in St. Louis, Missouri.
St. Louis?
Yep.
Huh.
Yep.
So because whenever they say, oh, we're separate, and it's like, okay, what is your address? 211 North Chicago Avenue. Okay, that's in the 22-story ADA building.
Yeah.
But you're in a completely different city.
Completely different city. Yep, St. Louis. Missouri.
And out of the 10,600 orthodontists, what percent of them, how many of them are members of the AAO?
Ooh, I don't know that number. I probably should know that number.
You think it's half?
Over half. It's over half. I think it's in the 70 to 75% range. If I were to guess.
So what did you think of that? Because basically Texas said, if you only do one thing, like say you pretty much only place implants, then you're an implantologist. You can call yourself a specialist. But you're saying that's now being appealed, or
it's in the appeal courts right now. I don't know what the outcome is going to be, but I mean, it is what it is.
Who do you think should be able to declare a specialty? Do you think the AAO should be able to declare that orthodontist specialty, or do you think it's a board issue in each state, or is there any national?
Wow, you're really getting deep and asking hard questions now.
Who
that's a good
would regulate
question.
that at a national level?
I don't know. There are a couple of individual non-dental entities that want to do that sort of thing, to be independent and administer that. I know I've heard of a couple of entities. I really don't know. That's going to be up to, I think, the state legislatures, and I don't know if the federal government will get involved. But I think that's what it's going to come down to, is each state regulating that themselves.
So let's talk about. I'm hearing that the average orthodontist is doing about 15% Invisalign. Is that what you're hearing? That seems to be the number thrown out.
I don't know that.
So you got out of school. You got out of school in 19. You went to Baylor in 97. You got out in 99.
Yep.
What percent of your practice was clear aligner Invisalign in 1999, and what percent is it in 2017? Almost 20 years later.
So in '99, our entire residency group went to an Invisalign meeting for the first time, and got exposed to it. I didn't start my first case for probably almost 4 years after that. And I just wanted to see more cases out there before I felt comfortable doing it. We were in a very evidence-based residency. Lots of articles, show me lots of cases if there's not articles about it before I'll jump in and do it. So that's the way I went about it and waited longer for that. Now, I started to realize if you waited for everything to go through all that vetting process, you'd never try anything, and I've become one of those people that will try just about anything. And that's what led me down to the Carrier motion. But I think 15%, I would bet it's higher than that in practices now. That would be my thought process.
Yeah, it's higher than 15%?
I do.
Yeah.
It could very well be that, because some people dabble and
Is
some
there any
don't.
stereotypes that fit Invisalign? I mean, is Invisalign just for like adults who say, I'm not going to show up to work in braces? Is it mostly adults and the kids are all in brackets? I mean, who is the typical Invisalign case?
I'd say the majority of the Invisalign cases, and I'm sure Invisalign has the numbers to look at that, the majority would be adults, young adults, working adults. But I think one of the biggest increases is in the teen market. And again, social media and social awareness and all of that stuff that's coming about, the kids want to show less and less of what they're doing. Everybody knows what they're doing, but in their minds they want to show less. I'm putting on a lot more clear brackets than I ever did. And so I have a lot of kids coming into my office asking for Invisalign. I mean, physically asking for it. So I think the numbers are going up on the teen side, but I do still think that it's mostly on the adult side.
You know, a lot of times, I fly a lot, lecturing and stuff. A lot of times I'll be sitting next to one. I've heard more adults say, you know, I get braces, but I remember when I took my daughter in for braces, I don't want to sit in that bay with 5 kids, and I mean, I'd feel like a dork. You know, everybody in there is 12, and I'm 40. Do you think a lot of adults are afraid to go into the orthodontist because of the bay system?
I don't think so. The funny thing is, I have 3 offices, and one of them is in a pediatric office. And my number of new patients that are adults in that office is probably I can tell you from my last review, which was almost a year and a half ago, was exactly the same number. Adults that came to my main office, which is strictly ortho, and it can be in their own personal adult room. And then the pedo, completely open bay with the little kid getting his teeth cleaned right there and one getting his filling right over there. Same number of adults. And we tell them ahead of time, too. We say, this is a completely pediatric office. I don't think it's that big a deal, honestly.
So they're not having problems with it?
No, I have nobody say, hey, I don't want to be seen in the open bay. The ones I'm treating.
So when you tell a consumer, or if a consumer says they want an ortho, there's just 2 main thoughts they have in their head. One is, oh my God, it's going to be expensive.
Yes.
And number 2, oh my God, it's going to take 2 years. So let's address the 2 years. When I first learned about ortho in dental school in '84 to '87, I thought to myself, if someone could figure out 24-hour ortho, they could charge 3 times more. It wouldn't be a $3,500 case back in '87. They could charge $10,000 if you could do it in one day,
like all in 4.
Yeah, and do you remember the first guy who was trying to do the fast ortho, where it was 2 brothers, one's an orthodontist, one was a periodontist, and they were sectioning in between all the teeth.
Mm-hmm.
Do you remember that?
Yeah, it's
what was it? The
Wilcodontics.
Wilcodontics.
Yeah.
So when I saw the first Wilcodontics case, I just thought, holy crap! I mean, this is extreme speed. But my question is. We're hearing that there's things that make orthodontics go faster.
Right.
Do you believe that?
I do. I'm seeing it. So Dr. Shipley, who I think you talked to earlier today, he has enlightened me to microperforations. It was something that I had seen. I thought, I'm not going to do that in my office. I don't want to use topical. I don't want to inject people. I don't want to do any of that kind of stuff anymore. But there's just certain types of cases, certain people, certain teeth that just won't move at the rate that you want it to move. And this really works. Accelerated orthodontics is here to stay, and it's going to grow more and more, and it's being more widely accepted. And so, yeah, I think it's still going down that direction. Now, it'll never be 24 hours. That'd be nice. I always say if I could snap my fingers and make your teeth straight, I would do that. But I don't think it will ever go down the path of being that fast.
I dream a genie could do it.
That's true. That's true. Yeah.
So you believe it works?
I do.
And are you doing it one time per case? Are you doing it every 3 months? Do you do it on all your cases? Do you just do it on some cases?
Right now I'm selectively doing, because I'm still in the learning curve with it. So, and I'm very upfront with my learning curve on patients. I'll tell them, hey, this is one of the first few times I'm doing it. Usually I don't charge for it the first few times, because I say I want to learn from this. And I show them I say, hey, all these people are doing it. Here's what it is. I'm seeing it happen. There are many of my adult cases, especially adult females, who their teeth just won't move. It's almost like they're rock. You put those perforations in there, come back, and one visit later, it's moved significantly. I firmly believe in it.
Now, who makes that?
Propel is the system that I'm currently using.
But they got two devices. They got this micro trauma.
Yep.
Microperforation.
Microperforation. Yeah.
But they also got a vibrating device.
Right, and there's a couple of companies that have vibrating. There's other companies out there, not just vibration. They're using laser and light to help accelerate treatments. It all comes down to blood flow, cells, everything to bring that to the area to make bone change. It's all about bone change. So all of these things are just doing it a different way. And so, yes, they have the vibration device, and so does another company. Excellident has one that does the same thing.
What is Excellident doing?
Excellident has a different frequency, but it's the same. It's a vibration device that vibrates at a certain frequency. You use it a certain amount of time each day, and they talk about making treatment accelerate. I like Excellident and the Propel accelerator to do Invisalign especially. Part of what makes Invisalign go is you have to seat those trays. Something's got to seat the trays. Bite seats it, but not in every person can they bite everywhere that they need to. These trays, we've been using Chewies, which are just looks like a cotton roll but made out of rubber that you chomp down on to help them seat into place. The vibration actually helps them to seat further and faster. And the thing I love about the vibration devices is that they do decrease discomfort. They shorten the amount of time you have discomfort, or you don't have discomfort at all. I'm seeing that on a regular basis.
So just the tray being fully seated and doing its forces correctly reduces discomfort.
It's not the seating of the trays. It's like a baby's teething ring. Babies are chewing on things. They don't know why. It's like when you give an injection, Galgate. You shake using proprioception to override the pain sensation. So I think that's a component to it. The other component to it is squeezing out many of those chemical messengers that cause the discomfort. It's squeezing out much of that fluid that causes the discomfort faster. And I can honestly say it does make discomfort go lesser. I'm using it on my own daughter. I've used it on many, many patients, and I ask when they come back, how long were you sore? People that didn't use the acceleration were sore longer on the average than the patients who used it.
Wow. So let's switch to the other concern. You tell mom she needs braces. Like, oh my God, this is going to be, what are you charging now? $6,500 for a case?
I'm sure the average is somewhere around there. Yeah.
Yeah. So switch from technical to business. I mean, how do you sell a $6,500 case? What are your thoughts on that?
So maybe I'm not the best business person because I try not to sell to patients. I'm more of the here's what we can do. Here's the cost. Here's a realistic expectation of your outcome. There you go. I never tell a patient I'm going to make them perfect. I say I'm going to shoot for excellent. We're going to get a good result, but I'm never going to make you perfect. If you want perfect, go down the street. Someone will tell you, and then when you're not perfect, you can come back and say I told you so. My big focus has always been to provide the information and let them make the choice. If they ask me what would I do, well, I tell them, if this is my daughter, this is what I'm doing. I don't have the monetary side to go by with it. And if you do it in 2 phases, which is my passion, I tell them up front, you're going to pay more by doing it in 2 phases. So I'm not a big salesperson. I probably lose business for it, but I walk out the door every day feeling good about what I did. Not that I was pushing somebody to do something.
Whenever a parent asks me, what would you do if it was your kid? I said, well, it was my kid. I'd hit him over the head with a shovel.
Have you?
And
just shove them into the pool or onto the trampoline?
Yeah.
That's what you do. Yeah.
Is there, so what, do you remember Orthodontic Centers of America?
Yes. Gaspar Lazara.
Yeah, out of St. Louis, out of New Orleans.
No, he was out of Florida. Jacksonville, I believe, was where he was originally from. I may be wrong, but that's where he opened up his first center.
Okay, I thought he was born in New Orleans. And
it might have been.
But I don't know. But it's interesting that, what is your whole take on that? Because when I got to school in 87, they were publicly traded on the New York Stock Exchange. Yep. With $1 billion markup, the only dental company ever made it to the NYSE, as far as a DSO, Dental Service Organization. There are a dozen on Aztec. They all imploded. Then they were gone for a decade. Now they're all back. But you notice that Wall Street doesn't want any of them back. Not one of them. Not one corporate chain. There's 35 corporate chains that have 50 or more offices. Not one of them could call it Wall Street and go public because they're like, no. But a lot of the younger dentists think, oh my God, these are going to take over all of dentistry. It's like, dude, you and I are old enough we've seen this pitch before. Yeah. So you're an orthodontist. A lot of these kids don't even know what Orthodontic Centers of America is. They have to Google it. What was the story for that? Why did that go away? And what lessons do you think were forgotten that could be applied in 2017?
So that's a very interesting topic because when I was a resident, is when it was at its height. And our chairman took us to one of his meetings. That was in 1999? Yeah, so I believe this was in 98 or 99. It was on the east coast of Florida. I can't remember where exactly. Amelia Island, I think it was. And our chairman took us to listen to Lazara speak. And he didn't put any pre-notions in our head. It was very open. He wanted you to hear a little bit of everything, so you know what you're getting into when you get out of school. So we went and listened, and then we had come together and had a discussion after. And there were a couple of things that just did not go well with most of our fellow residents. And number one part of it is that if they educate you, you have to serve them for so long. It's like indentured servitude, and none of us like that. The second component was that if you left them, that's the center's cases, not the individual practitioner's cases. That was their cases. Now, by most state law, that's not the case. The patient is the responsibility of the doctor. But he argued against those two big components. And so that's, to me, what's going down that path with all these. And I get it with the young kids. They're so in debt. I mean, how could you not? You're coming out of, the least I've heard recently is $450,000 in ortho. And we were hearing couples that are in the 1.2 million coming out. So they're just looking for the easy, fast fix. They're not looking at what's going to happen to them after that fact. And that's something that I blessed Dr. Malcolm Meister, who was my chairman.
Malcolm Meister?
Malcolm Meister. So he was
Is that a beer or a person?
Right, you would think.
Sounds like a German beer.
He's an unbelievable man who was an orthodontist, went back and got his MBA, then went back and got his law degree, was practicing for the public defender's office after he retired from orthodontics, and then was asked to come and be the chairman of our department. Our department was so...
Is he still around?
Yes. Well, he's still around. He's still teaching at Nova. We just had dinner with him just recently, and he's still there 2 days a week.
Email him and CC me. Zach, do you have any more of my cards?
I will.
I'm Howard at Dentaltown. I would love to meet a guy. He's
unbelievable. So here's stuff we had to do. We had to read Atlas Shrugged as part of our residency. He believed that we were much more than just orthodontists. We were going to be a contributing part of a community, and we needed to know that. We studied the Roman Empire. We had to label all the capitals of the world. It was a test. Don't ask me to do it again. There's no way it's going to happen, especially with the change in Russia. But that was part of what we had to do. And his whole global philosophy is you are not just an orthodontist. You're a family member. You're a father. You're a business owner. You're the leader of a team. You need to know the greater component. So he led us down that path of letting us lead our own way. And he would lead the discussions, just like I think the method in law school they let him do. And that's why we went to see Lazara. That's the number one reason. He didn't want us to go down that path. You could tell he would never say that. But he was letting us make that decision.
So why did it fail, though? Why did Orthodontics Centers of America, why did it implode?
That's a good question. I don't know. And especially once they started building all the dental schools for more kids to go, I thought it was taking off, and then all of a sudden it didn't. I really don't know. That's something I never really got into to figure out what had that happen, other than maybe there were many of those kids trying to get out of these contracts, and they were getting out, and they wouldn't have enough people to practice for them. I don't know, honestly. I wish I knew that. You may know. I don't know.
My guess, what I see the parallels is what a lot of people don't realize, these DSOs have always been a liquidity game. If you sell a house in America, a 3-bedroom, 2-bath house in Phoenix will sell today. You list a 3-bedroom, 2-bath in Phoenix, you can dump in a week. But if you're an NBA player and you had a 10-bedroom, 5-car garage deal,
right,
like Tony Romo, his house might be up for sale.
Right. That's true.
Is his house going to be up for sale? Are they going to pay him all that money to be a backup?
No.
Yeah. So when Tony Romo puts his house up for
right,
sale, which I imagine is larger than a 3-bedroom, 2-bath.
Maybe, yeah.
It's an illiquid asset.
Right.
And I think what Lazarus and those guys realize is that a dental office, the ones that sell, are $750,000 in revenue. So you find these orthodontists that were doing 2, 3, 4 million. They couldn't sell it to some kid coming out of school.
Right.
So he gets a big line of credit and he starts buying up liquidity. Well, so you sell your practice, and that guy says, well, okay, well, you have to work here 3 years. So at 3 years and 1 minute, they're gone. And then they replace you with some kid that just came out of ortho school. And that kid might have gone in there and done like $1 million, which is like a phenomenal achievement. But he was supposed to do 2 or 3 million. So they would just, whenever the selling doctor would leave, it would nosedive. And it would nosedive to a place that I thought was like twice as good as it should have been.
Right.
So it was a liquidity. And I think once Wall Street realized, okay, we're just buying a bunch of 65-year-olds and replacing them with a bunch of 25-year-olds, that really ain't a good idea.
Right.
Because when you get out of ortho school, in all honesty, how long do you think it takes you to to ramp up and just be hitting on all cylinders? You're not going to do that in a year.
No.
You're not going to do that in 2 years.
No.
How many years is that process?
Yeah, and for me, I went out into an associateship, which was the best thing. I actually worked for a guy that I was a chairside assistant and a lab tech for him. I didn't learn any more about orthodontics. I think you got to do that on your own. I learned more about business, staff. How do you grow? Where do you want to grow? I learned all of that stuff from him. So for me, I gradually worked my way into it. So I would say it took me as an associate, where you got the data right there in front of you to tell you, it took me 3 or 4 years before I felt comfortable going out and really doing it on my own. And that's what I ended up doing.
Was that in Dallas?
That was in Dallas, yeah. And a great guy named Mike Plunk, and he's my kid's godfather, and love him to death.
So that means you're Catholic?
Well, I was Catholic. I'm currently Methodist, but
Methodist.
I was. My wife is the youngest of 6, and
yeah.
So we're
she's
two
raised
Catholic
So you're
families
both-
came together.
I have 7 kids Catholic. 2 oldest ones went straight to the nunnery, straight out of high school. At 18, they entered the nunnery. But if you were graduating from ortho school tomorrow, would you recommend start up your own or be an associate?
No, I would go be an associate wherever possible.
For how long?
At least 2 years, if not longer. If not longer. And I probably made a little bit of a mistake by not having a buy-in agreement with him before I did it, thinking it was going to work with us, being a little naive from that perspective. But I think associateships and really learning what it's all about, not just the orthodontic side, but everything, because orthodontics is a small percentage of it. It's like in any dental medical law practice. It's all the same to me. I think they should go out and associate for 2 to 4 years and maybe even try it with a couple of different people who are willing to do that with them before they go out and try and start. And starting up from scratch, to me that seems very, very risky in this day and age.
So I want to ask you, podcasts are big fans of people under 30. I'm 54. I'm probably the oldest guy in America that's listened to a podcast. I mean, my own friends don't even. If I put a gun to my 5 best dentist drinking buddy friends and told them, find a podcast on your phone,
Yeah.
I'd have to shoot them all. But a lot of them are wondering, they're in school, they're thinking, what if they told you in dental school that they wanted to be an orthodontist? Do you think that's a good idea, bad idea, time has come, still good? What would you say to a kid in dental school who thought he wanted to be an orthodontist?
Well, I mean, if you want to be an orthodontist, you should go and study and be an orthodontist. I relate that back to why was the suicide rate so high for dentists for so long? It was because they settled for dentistry because they could get into dental school easier than get into medical school. They settled. And nowadays it's not that case. That's not the case. I think it's probably more competitive to get into dental school than medical school. But if you settle just because, you're never going to be happy. And even if you're in debt, you should go do what you really want to do. So I would not discourage them, but I would encourage them to start finding relationships while they're in their residency. Find the area they want to be in and foster some relationships with some dentists, and not the fact that I just want to buy your practice. Hey, can I come ask you questions when I need to? Can I come just observe for you? If you're looking for associate, keep me in mind. That's what I would do. I can tell you, I get letter after letter in the mail from these kids that want a place to work. I have yet to get a phone call from somebody that says, hey, can I just come over and hang out with you and talk with you? And I think it goes along with the whole social media push too. I mean, you're on your phone. You watch dating. I watch my daughter who's starting that process, and then I can't stand it. There's still something about that personal connection, and a person that's looking to bring someone in wants somebody that will interact with them.
You sound like my old man. So Zach,
I know. It's hard.
I
It's
never
hard that way.
know if I tell you this, but so I grew up with 5 sisters, right? So they go these dates, and they had to wait till they were 16. But when the guy came, most of them would just honk. And my sister's like this because my dad's in there, and my dad said, if you don't have the guts to come to my front door, knock on it, shake my hand, you ain't touching one of my daughters. And only like 10% of the guys were smart enough to come to the door and press the flash like you're running for mayor with dad. And my sisters they do the dad. That was the interview. They'd never be able to date that guy again. I mean, he was too, quote, chicken shit to come up to the front door and knock. And that's the same thing with resumes. I mean, people say, why is there not 10 resumes? Well, did you get out and press the flash and knock on the door and say, hey, I sent you a resume earlier?
Yeah, no, I think that interpersonal relationship is so big. And that's what you're going to do when you get out. People half the time don't know if you did you put them in a class 1 perfect occlusion? How did you treat them? Did you treat them the same way you'd be treated elsewhere? And if there was a problem, did you step up and say there's a problem? And that's something that I teach my staff to do, and I try and do too. If I don't know what's going on or something went wrong, I'm the first one to pick up the phone and call somebody.
Another thing the millennials do, my biggest pet peeve with millennials, they come out with all this student loan debt, and then they say, well, I want to practice right downtown Dallas so I can see the stadium. It's like, yeah, you and everyone else, but if you drove an hour away from Dallas. So my question to you is, does demographics matter?
Yes. Yeah, demographics matters in a multitude of ways. Number one, you need to know what demographic you're treating in your own practice. You can't put marble up in an area where people are going to view that as he's just he just wants to have a Porsche and drive around and everybody see him. You can't do that. And it's the same thing with where do you want to practice. Everybody wants to practice in the city center. You want to go to dinner, you want to have groups of friends, all of that. But you've got to weigh that to your debt, to everything else that's out there. And there was an article, I just read it on the plane, I don't remember which magazine it was, but it was talking about that specific thing. It says that kids need to look outside of their comfort zone box and push outside. Maybe you got to drive a little bit, live in the city, push out to that way. But you really need to live in the city area, I think, that you practice in. But I think demographics are huge. And that's what they're looking for. They want to practice in the heart of Dallas. And the numbers keep growing in my area, I can tell you that. It's crazy.
Yeah, and I keep telling them that this commute is going to be over. I mean, we're this close to driverless cars.
Yep.
So it's not going to be an hour commute, driving, stressing, all that. Hell, it'll just be like a box. It may have a bed in there. You might have a lazy boy and watch a movie. You might be on your email. The commute's not even going to matter within 5 years.
Right. And then video conferencing, you can talk to your sister in another city while you're driving, and all those things. So.
I just think demographics are huge. So another thing, some orthodontists think, I'm the orthodontist. Only I should present the treatment to the patient. Other people say, I look at the close rate. I think the treatment plan coordinator should do it. That her skill set is selling. Most dentists will honestly tell you, I hate sales. I don't want to sell any dentistry.
I don't.
So who should present the treatment? The orthodontist or the treatment coordinator?
My personal opinion is the orthodontist should present the treatment, and the coordinator should present the process. And the process includes payment options. And I try and separate myself. I don't want to be worried about, is this person behind or not? So I think that I present everything. Here's what I see. Here's the problems I see. Here's what I suggest that we use to correct it. And then I'm going to let my person come in and talk to you about, here's the process, here's what it is, show you the model, you can play with it, you can ask questions, and if you have anything else, I can come back in and ask it. So that's my way, my philosophy of doing it. They're paying for me to diagnose the case, and I'm going to let my treatment coordinator go through the rest of that. And again, I already told you, I'm not a big salesperson, and I probably lose people because of it, but I'd rather not force somebody to do something they don't want to do.
And are you carrying the paper on this ortho, or do you sell it to a third party like a Care Credit or a bank? I mean, can I make payments to you, or do I got to get a credit history, outside financing, so you get all your money today, then I make payments to them?
I currently just do it all in-house. I don't have
You carry your own paper?
I do. And my collection rate is uncollectibles is pretty low in my area.
What is the number?
It's about 4%.
4%, that's nice.
Yeah, it's not bad. So I'd, of course, love it to be 100%. But that's not to say that I don't believe in the third-party side of things.
So why did you do it? Why did you carry your own paper instead of selling it? Because if you sold it to like a third party, like a Care Credit, it cost you more than 4%.
Right.
Well, what would it cost you?
It probably costs seven or more, I think.
Yeah.
I'm looking at it from the busyness perspective in my office. I'm at that sweet spot I like right now. I like the number of patients that I see. I like the number of staff that I have. But I'm starting to hit that point where it's getting a little bit more. And so to make that feasible, I could see how you could eliminate the headache of another staff member, pass that on, and that percentage that you're letting go out the door covers the cost of one less staff member. So it's kind of a headache thing. And insurance is so tough to call, find it out, submit the paperwork. Oh, we didn't get paid. Go back to them. You have a staff member who has to spend almost all day on the phone. So, some of the companies take care of that for you too. So I see the true benefit of it, and I could see myself going down that path at some point. It's just that when I started out, there weren't a lot of those options out there, and I did it based off of what the guy I was in with. He financed it. He did this, and so I went down that same path, and it's worked for me. So I've stuck with it to this point. But I am getting to that factor where it's pushing that envelope to I've already talked to a couple of different companies, and I'm looking into it for sure.
So are you participating with a lot of PPO plans for orthodontics?
I accept them all. I don't participate with any of them anymore. I'm not on any plans. I was for a long time. I tried to negotiate with them on price as the cost of living went up. They didn't go up. I mean, a couple of the companies didn't go up for years.
So what does that mean? So you don't participate with them, but you accept them?
I do. I accept them. So most companies will pay in-network and out-of-network. I'm out-of-network, effectively.
Explain to the kids what that means.
So in-network is you sign up with a company. you agree to abide by the fee structure that they provide to you, and you must abide by that. So you can't charge them any more, any less than that. And then they have a percentage of, say it's $1,000 a year that they can use towards their treatment. Being out of network, I charge the fee that I feel is appropriate for that type of treatment. And then I collect a percentage, usually $1,000. In many cases, it's the same whether you're in network or out of network. I get that percentage from the insurance company, and I collect the rest from the patient. The benefit of being in network is that, from a marketing perspective, you're on their website. When people are searching for somebody, you're going to be on there, but you're paying for it and having to see more patients. I made the choice because I would rather see fewer patients and take care of the fewer patients than have to increase my numbers so much to make it equal and worthwhile. To me, it wasn't worth doing that. My staff was still spending the same amount of time filing insurance, even when I was in network, to get them to pay me. Why was I discounting my fee and seeing more patients to do it? It didn't make any sense to me, so I got off the networks.
So a lot of us believe that have been around the block a lot of times that America is it's a big country. It's a third of a billion people in 3.5 million square miles, and the market pretty much breaks up to half of the, and just talking dentistry, not cars, boats, but half of the people are chasing price and volume, and the other half are chasing value. And so you're a value play in Dallas.
I am.
And there's nothing right or wrong about either model. I mean, some people take the bus and drive a Ford Escort, and some people own a $30,000 Honda Civic or Ford Taurus. So you're a value play in Dallas.
I am, and I know there's consumers the same way. There are consumers who will go shop at the thrift store for the stuff that they want, and they'll go to a value orthodontist because they value that healthcare component for their patients. I have many patients that you misjudge patients, so I don't do that. I have, here's my fee based off of this type of bite. I go with it.
So I'm here in Phoenix, and I'm 100 miles from the border. So I have a friend that sells pharmaceutical tubings for after surgery. So you drain.
Yeah.
So the
pen drains or whatever.
Yeah, the pen drains.
Yeah.
Guess what the number one clients are in Phoenix, Arizona? People who went south of the border to save money on a boob job, a tummy tuck, liposuction, whatever. And they're freaking going to be wearing a surgical drain the rest of their life.
Right.
I mean, it's just
you get what you pay for.
It's like, man,
you get what you pay for.
You went to a third world country for a surgery? Are you out of your freaking mind? So I said this, I said specifically, I mean, are we talking about in Phoenix, like, is there like one person that has this or two person? She goes, dude, your average nursing home, probably 10% of those clients are post-surgical cases from Mexico. Because
that's insane.
Because they wanted a boob job for half the price.
Right. Well, and they'll look at, and I know many of those doctors doing it across the border are trained here, but they're doing it volume, whatever they're doing to make it happen. It's crazy to me. I can't explain it.
Yeah, and it could just be a few bad eggs. I mean, it could be 90% of them are amazing, but there's not a checks and balance to get rid of the bottom 10% that aren't amazing.
I don't want to wake up in a bathtub missing a kidney.
Yeah.
Like some people would go do, you're put under for something, and the next thing you know, something else happens to you. To me, that my brain doesn't work that way. I'm running.
Well, hey, congratulations on speaking at the biggest ortho meeting of the year, and thank you so much for all that you've done for orthodontics and dentistry, and thank you so much for coming on my show.
Thanks for having me.
All right, buddy.
It was great. Thank you.
Thank you, Zach.